Much. Hemophilia itself is a chronic disease. We know it is a time immemorial. It's known from time immemorial. But as far as doctors are concerned, their knowledge of hemophilia still remains the same. Last 30 years I've been treating hemophiliacs, but the awareness and the knowledge of doctors is the same. And they think, oh, we'll refer off to Naldi Kanapidlam. We get calls, I get calls from all over. Doctor or patient. We all know about the gene of hemophilia. It is a X-linked recessive disease. So males are affected more than the females. Now, what is bothering me is females are also getting affected now. I want to tell you that more and more we are detecting more and more females with hemophilia. All male children are normal, female children are carriers. We know all this. I'm not going to talk about it. Carrier female. They can also have a normal child, a girl child, which can be affected also. Can females have hemophilia? Yes. Consanguineous marriage, we thought, uncle, niece, first cousin marriages. In Turner syndrome, then low factor level carriers also suffer from hemophilia. They all have bleeds. Now, I'd like to tell you about this pair of twins. This children's brother is a hemophiliac. So when the mother conceived, we sent her for antenatal testing. We found that the boy is not affected, but the girl is suffering from hemophilia. So we are getting more and more females suffering from hemophilia. Antenatal diagnosis is limited, done only in few centers. Prenatal diagnosis done only in very few centers. They have to pay for it. So many of the patients cannot afford. So they go on to have a second child with hemophilia. Now, what are the common problems which become chronic? As we know, they're all very prone for joint bleeds. Knee joint is the commonest, hemarthrosis. It becomes chronic when they are not adequately treated. When you see the joint, if the blood stays more than 24 hours in a joint, joints repeatedly get traumatized and they have bleeds, and they all by 15, 20 years, they all have chronic changes. And many of them can become handicapped like this, especially in the rural-urban divide is more, because the rural patients' access is poor, knowledge is poor, so they come to us late, and many of them have crutches, but now things have improved compared to what it was. These are the chronic hemarthrosis of my patients. They all think we can go a little later. If you don't treat within 6 hours, then the joints get affected. So chronic hemarthrosis is still a problem. Treatment for hemarthrosis, adequate factor prophylaxis, to prevent further bleeds, they have to go on prophylaxis. Then, if we wait for 6 months, if it doesn't become better, we are doing radiosynovectomy, which has got P40, has got very good results. We are doing it free in Jipmer. In Vellore, it costs 2 lakhs. Of course, physiotherapy, yoga, cycling, swimming. These there is nothing equivalent to doing physiotherapy and exercises, which will improve the muscle tone, so number of bleeds become less. Other is the common site for bleeding are the muscles. Among the muscles, the muscle which becomes chronic is the iliopsoas bleed. You can store up to 8 liters of blood in iliopsoas muscle, and it takes about 6 months to heal. Nobody waits for 6 months. They all wait for 2-3 doses of factor, then start doing their work. So this becomes chronic and then it becomes recurrent. So they all suffer from iliopsoas bleeds. The other thing is the vehicles they use as they become adolescents. Children start using heavy bikes, and the iliopsoas bleed then becomes common from these children. Psoas bleed must be treated by hospitalization, traction, followed by graded exercises. These people have no time for that because many of them are in school or college, 9th standard, 10th standard, 12th standard, or they are in college. So they have to go back, or they are working. So they have to go back, and hence it becomes chronic. Then the next, not a very common thing, but we do have pseudotumors. Inadequately treated hemophiliacs develop this. Pseudotumors can happen anywhere. It can happen in the thigh. It can happen in the, you see the thumb of a child where it has become a pseudotumor. We have to give treatment and also do surgery for these patients. This is a pseudotumor of the abdomen where the patient had a large pseudotumor. I thought it was a spleen, but finally it turned out to be a pseudotumor. He developed inhibitors, and then finally we lost the patient. He was a college student doing engineering. We lost the patient to that. We lost also a medical student who had a pseudotumor. He was operated in Vellore, and then he was there for 6 months. Then after that, he developed an intracranial bleed and died. Next, most important is the inhibitor, because inhibitors occur in severe hemophiliacs. About 25% of patients can develop inhibitors. It arises in childhood after median exposure of 50 days early in childhood. Influenced by mutation, patients having large multi-domain deletions are highest risk for developing inhibitors. Another is F8 mutation, where there is an intron inversion. These patients are a big problem for us because they have recurrent bleeds, they don't respond to factor VIII, and we have to give other bypassing agents, which are expensive. You see, these are small children having inhibitors. They have recurrent bleeds, and they have to be given other treatment. The inhibitor bypassing projects are activative prothrombin products, APCC, FIBA, Autoplex, which are all very expensive. Then porcine factor is no more available. Recombinant factor 7A, you know the price of recombinant 7A, which is 50 rupees, 50,000 rupees. So it becomes very difficult for recombinant A. Then the other thing which has come in is immune tolerance induction, which involves repeated administration of factor VIII, which is 50 units per kg bi-weekly for 6 months. That means the availability of factor is very important for reducing inhibitors. This has come in a good way for many of these patients, but I have not tried it because of non-availability of adequate factor, because we need 50 units per kg bi-weekly. Every week, we have to give at least 100 units per kg. That means we need a high dose for these patients. Then the other thing which has come a long way is the monoclonal antibodies. Imizumab, which is commonly known as Hemilibra in foreign countries, works as a bridge between the clotting factors to replace the missing factor VIII. But this is also very expensive. For a frequent bleeder with recurrent hemarthrosis, I worked it out. He's about a 10 or 11-year-old boy. It comes out to 5 lakhs per year, which a patient cannot afford. Government is not supplying this still, but in Western countries, they have found that emicizumab has been found to be very effective in preventing, as a non-factor prophylaxis and preventing bleeds. Others also have been tried. Other is the lentiviral gene therapy, which CMC Vellore is going to try it out. It also helps in inhibitor patients to prevent bleeds because it maintains the level fairly well for a long time. Of course, AAV gene therapy is the long term, which we are expecting. But unfortunately, CMC Vellore has done a study in all hemophiliacs and found that many of our patients have antibodies against AAV virus already, in which cases AAV gene therapy may not be very effective. intracranial bleed. There are some severe hemophiliacs who have had more than 2 intracranial bleeds. It is very unfortunate. They require large amount of factor. Many of them also develop inhibitors. So these are 2 patients who fortunately recovered for us, but they all have inhibitors. This man is a very old patient of mine. He fortunately doesn't have inhibitor. He has had intracranial bleed, and we had to get him operated, and he required large amount of factor for this. And fortunately, he's well now. And GI bleed. This is one of my patients who had recurrent GI bleed. He used to come to Jipmer, take factor, go away. Then come back again with bleed within a month, become very anemic. We couldn't find the cause. Jipmer, they thought it was appendix because he had pain. So they thought, they opened and found, they thought it was appendix. But again, he continued having bleed. Then he had to be referred to Vellore, where they found it was tuberculosis. And he had a whole segment which had to be resected. And now he is well. So he required large amount of factor, large amount of blood, because his hemoglobin will come down to 3 to 4 grams. Every time we had to give him 2 units of blood in addition to factor. And now, fortunately for us, he has been well. So recurrent GI bleed is also possible. So we also have to think of other diseases which can complicate hemophilia and then produce bleeding. Oral bleeding, of course, is very common in children because of their caries teeth and poor orodental hygiene. They come with recurrent bleeds. We do have a dental checkup for them once a year or once in 2 years, clean their teeth and also do the caries for them. Otherwise, they all develop recurrent oral bleeding. Now, coming to females. I told you females are becoming a problem with hemophilia. They all have menstrual problems. Most of them we manage with tranexamic acid, but some of them require factor infusions. And the other thing is, during surgeries or during delivery, we have to support them with factor, especially the carriers and some of these patients. The other thing is, von Willebrand's disease patients have low factor VIII. So they have to be treated for not only for von Willebrand's, we also have to give them factor VIII. Dr. Murugesan, you would be interested to know, I've got 2 von Willebrand's right opposite your house, who are all my patients, 2 girls. One of them have just attained menarche. She is also factor VIII deficient. So we have to treat them with factor VIII, as well as they all have symptoms like hemophilia. They have joint bleeds in addition to menstrual problems. Counseling is what is needed for these. I've got one more small girl like this. She's a factor VIII deficiency with von Willebrand's. Now I find large amount of von Willebrand's patients also have factor VIII deficiency. General health for these patients is very important. Pain tolerance, chronic pain is a problem. As far as possible, we have been giving paracetamol. The next is tramadol. This tramadol is given during acute problem in JIPMA. These patients become dependent on tramadol, and I have many drug addictions to IV tramadol. These patients go to the nearest pharmacy and take IV tramadol. Recently, a boy came, then we told him, please stop tramadol and then take, and homeopathy comes to our rescue in those places. Homeopathy for pain. We are giving drugs which can reduce their pain and also improve their general health. We also give prophylaxis for these patients. Anemia is a big problem because they have small bleeds all the time, and malnutrition. This boy is a 13-year-old boy, one on the left side. You see his growth, he's chronically anemic. The one on the right side is 11-year-old. He just weighs about 15 kg. So malnutrition is another problem in these children which have to be taken care of. Adolescent obesity is a big problem. Many of my children, 12-year-old, 13-year-old, weigh 60 kg and 70 kg because they don't play, they keep eating, they sit at home, especially during this corona period where there was no school. They keep eating snacks. And especially when they have a bleed, they eat nothing except snacks and some juices. They starve. Mother thinks, at least let him take this. Let him take some chips. They keep on eating. And so obesity becomes a problem. This boy, who is just 11-year-old, is 60 kg. How to reduce weight is a problem because diet control is very important. The other thing is osteoporosis. So we have to give them calcium and vitamin D routinely to control, otherwise they will develop fractures. Then the social problem, why me? If there are two children in the house, one of them has hemophilia, other doesn't have. The young boy asks, why I alone have hemophilia? Why not him? I have to get multiple injections, but not he. See, this is a problem. This is one which always they bother the mother about this. So we have to counsel them. Next, counseling for depression. Drug addiction, as I told you, adolescence is a big problem. Sleeping tablets for pain. Then tramadol. They take all sorts of drugs. They take to drugs, alcohol. Some of them, this boy on the left he had a bakery of his own. He was a very nice boy. Suddenly he committed suicide. Why? We still do not know. The same way, so we have youth themselves counseling them. We have a counseling, we have a drug de-addiction, we do everything for them. We get a psychologist and a social worker to come and counsel them also. And we have youth groups who talk to each other about their problems. Social problems are still there. Physical disabilities, low school attendance. So financial constraints, living with the risk. These are common questions they ask. I tell them, if you have proper physical exercise, have prophylaxis, then you can play contact games. Vehicles are again a problem. Heavy vehicles, and they all develop bleeds. They don't wear helmets. If they like something, they can do it. You see, my children, they danced continuously for 1 hour during our Silver Jubilee. Nothing happened to them. If there is something they can do, then if they like, then they don't have bleeds. And this is again a problem. I'm not going to talk much about this. Career option, all this counseling has to be done. Now our successful stories. On the left side, we have a neurologist who has struggled his way and then come up. On the left side, we have a doctor, a budding doctor. These are some of our successful stories. To conclude, hemophilia is a difficult disease, but can be conquered. Chris Campardier, who's a hemophilia, climbed Mount Everest. We have a marathon runner. We have one in the army also. So all that truly matters is the lives you have touched and the people you have loved. Thank you. I love all my kids. Thank you.
Thank you, Dr. Nalini, for elaborate lecture on hemophilia and shown nice pictures of the patient. Now, the topic is open to discussion.